So we've been referring to the history of HIV/AIDS, and in particular the critical historical point when the WHO gave up most of its AIDS responsibilities and passed them on to UNAIDS and many of the things that followed. Mike Merson, of course, played a central role in that process, and will speak to us about how he experienced this and how he sees this looking back. But at the same time, this is not an autobiography. I think that's very, very important to say, which is why Stephen Irnig is sitting next to him, Stephen, who's a historian. And therefore, in the conversation between the two of them, this story was told in an analytical way, a way that is not just about one person's perspective on what really happened, as important as those perspectives are. And of course, for me, reading the book, having been at WHO at that time, and actually at the regional level having some responsibility for WHO, it was also very interesting to read. And then you keep having, as we say in German, these aha moments, you know, oh, that's what happened, you know, or oh, that person, etc. Which is why also it's very nice that many of you have responded to Mike's invitation, those of you that were part of this story and part of the process, and that there can be, you know, a discussion around some of those aspects that you lived through, that he lived through, and that some of us also experienced. So I'm just going to hand over first to Mike and to Stephen to sort of present to us what's in the book, what's important, especially important for them, and then we can go back and ask a few questions and maybe add to the story from your perspective. So Mike, I'll just hand over to you.
Sure. So thank you, Alona, very much for hosting us. And let me also welcome many of my colleagues from GPA, and thank you for coming. Just a couple of housekeeping. So we don't have copies of the book here. It's a long story, but we were unable to have copies of the book here. But there is a brochure outside, and you can get an electronic copy quite inexpensively. Also a soft cover, hardcover at a discount. If you just pick up a brochure outside and follow the code, you can get a reasonably priced copy of the book if you want it. Secondly, after this, for the GPA staff and really anyone else from WHO, we're going to have ability to have a little aperitif if you're available, and at the restaurant at the on the top of, I think it's the Pedal 5, is that right? We can go together after if some of you are interested to stay together a little bit longer and share what's happened to all of you in the past, and I welcome your coming. Anyone else as well. So to turn to the book, I want us to, one more thing. I want us personally welcome the wife of Fakhri Assad, who is here. Fawzi Assad is here.
Thank Merson, because otherwise there would have been no remembering of my husband who started the whole program in WHO. So much that he was called Monsieur Sida. Nobody knew his proper name.
Anyway, thank you, and your daughter is with you, so thank you. So I don't have to tell this audience about the AIDS pandemic, and sometimes when Steve and I have presented this, we talk a little bit about that. That's not necessary here, but you all know it's been a long struggle. The world has invested over $120 billion in this fight, and basically in this book, we wanted to tell the story of the struggle, how the world, and I'm thinking governments, UN agencies, civil society, and the private sector, for better or worse, responded to the pandemic. But of course, as Alona has already intimated, the book focuses very much on GPA, the Global Program on AIDS, which led the global response beginning in 1987. Now, this is 6 years after the first AIDS case was recognized, a decade before the discovery of HAART, at a time when AIDS was considered a fatal disease and the course of the pandemic was unknown. So try to put yourself back to 1987 as you hear this story. Now, GPA, and many of you know this, was closed down in 1995 after only 8 years of operation. At what we know now was the peak of the pandemic in terms of HIV infections. It was closed down because of concerns over the performance of the program, displeasure with the re-election of an unpopular Director General, and feuding between UN agencies. As many of you know, I directed the program. I was honored from 1990 to 95, succeeding Jonathan Mann, who was the founding director and resigned precipitously in March of 1990. He tragically died in the Swissair accident off Newfoundland in 1998. Now, more than anything else, I was inspired to tell this story because of the 500 GPA staff. This was, for me, the main motivation, who worked tirelessly and passionately to confront AIDS at what was, in my mind, the most difficult period in the pandemic's history. Also, many involved in AIDS efforts today have never heard of GPA and certainly not aware of what it achieved. I teach in 2 universities, and I can assure you of that fact. Many people also are not aware of what GPA did and how its closing and the behavior of the donors affected the global response. I think that that story, we felt, really had to be told. Now, the book also covers the period leading up to the establishment of GPA, when WHO's response to the pandemic was cautious, one could even say feeble, except for the response of Fakhri Assad. We also cover the period of the closure of the program, when UNAIDS faced considerable obstacles and challenges as it tried to establish itself as the successor to GPA. And then the final section of the book brings the reader up to date on the current state of the global response. So in a way, really in many ways, the book uses GPA as a lens through which to trace 36 years of the global response to the pandemic in low and middle income countries. So that's a big overview, and I'll turn it over to Steve so you can learn a little bit more about him.
So thank you too, Alona, for having me, and appreciate the opportunity to be here. I'm a policy researcher and a historian. Most of my work has been on health policy in the United States, HIV in the American South, and cancer in populations that lack insurance. And so this was a tremendous opportunity for me to think more broadly and really ask, how does the global health community use some of its major health instruments to address health emergencies and pandemics? And more out of that, we were trying to think of what are some lessons that we can learn to create kind of a useful history, not just one that tells a story, obviously one that pays attention to people, but also are there some things that we can learn? And I think that's kind of been one of the things we've been trying to do today, or to say, what did HIV and the response to HIV, both successful and unsuccessful, teach us that we can think about going forward? And some of the things we've already talked about today have ways that we've responded differently to pandemics since then because of those things. So we wanted to inform policy and practice, and then as a historian, it was kind of a unique opportunity for me to work with Mike, someone who's kind of a participant observer in the story itself, but also as a historian, I'm very interested in untold stories. And GPA in a lot of people's existence, it's not there, it's not told. And I taught for 2 years at Duke to undergraduates, and I didn't teach about GPA. So it was for me a lesson in learning. And then obviously, there are people who've sacrificed their lives, both professionally and literally, in this cause, and this was a way for us to kind of record their story. So some of those we'll talk about today.
Okay, so that's a big overview. Now, how did we put this together? I can tell you that I started on this process in 2001. Okay, so how did we get, what did it take to write this book? So the first thing I'll say is I was able to get into the WHO registry, that's a whole story into itself, in 2001 to read and have access to the entire GPA files. They were all there in the basement of the M building. Number one. Number two, we conducted over 125 interviews with key players in the pandemic, including some of you in the room, mostly between 2001 and 2002. We transcribed all of them, and Julian Mignon, I don't want to embarrass you, did a lot of that work for us. We drew from over 1,300 source materials, and when we had a reasonably final draft of the book, it was reviewed by 5 very knowledgeable and respected external reviewers to be sure that at least we had some additional outside review. We had one grant that paid for this, a small grant from the Kaiser Family Foundation, and what was, you could see, a rather exhaustive process. And now Steve, as a historian, will talk considerably more about how, as a historian, we approach this.
Thanks. Exhaustive and exhausting, perhaps we would say, but for me coming on, this is not a conventional history, right? It's a little bit like writing a Cold War history in the middle of the Cold War, because we don't know, we have hopes about how HIV/AIDS is going to end, but we don't know how it's going to end, and there's some concerns even now. And so writing a story about the history of AIDS is kind of abnormal to do it right in the middle. So that was one of the things. And the other is, when you're a historian, you like to work on your own. And so writing with someone who was a participant in this that can be a challenge, an exciting challenge. So I really set out to kind of do something we call triangulation, which was to get Mike's story and his perspective, but to try and get other people's perspective and the documentary evidence, so that when people read it, they felt like this wasn't just a memoir or Mike's hatchet job trying to get back at people who did him wrong, but really a fair and honest reading of what went on, obviously from Mike's perspective. And so when I agreed to come on board, first of all, he told me he wasn't going to pay me, but that actually gave me some freedom, and him some freedom, because then he knew that we were going to work together to try and do the best to tell the story. And so you need to buy the book, by the way. But he had obviously collected, he says he collected, it was about 10 linear feet. So you can ask his wife, because it takes up this entire closet full of boxes of all of this material. And before I looked at that, I created kind of a timeline from secondary materials and others to get some idea of what the story was before I went and talked to Mike so he could tell me what it really should be. And then I integrated, we scanned all of the documents that we had and put them into a chronological timeline. And then Mike and I just sat and had several conversations over many years, which I just recorded, which were very freewheeling, to kind of try and get at the story. And so it was kind of a combination of my research and Mike's experiences and Mike's research. And then what I did was go back and try and fill in the blanks. By that time, a number of the WHO documents were online, so we were able to access those. There was ample secondary literature from other social scientists and political scientists, and so we drew on those. And then I also conducted several interviews, some on the record, some off the record, just to try and get at the story. And what was impressive for me was the honesty, I think, that people provided me, and Mike's willingness willingness to be self-reflective, and for me to challenge him and him to challenge me. That's not something one necessarily, you know, when you're writing a memoir, you kind of want your story. When you're a historian, you kind of want your story. And so we kind of worked through this to try and aim for a story that was true to Mike's perspective and experience, but also one that people who might disagree with him would read and say, that's fair. That's what happened, or at least I can understand why Mike views things that way. And so we really did the best we could to try and create something that captured those things. And I think that's what we are talking about today.
Okay, so we can answer questions about this somewhat unusual approach anytime, really. But let's cover. I'm conscious of time, so we're going to cover three things. I'm going to speak about three things. One is what did GPA face in leading the response? Secondly, what were the challenges in GPA being shut down precipitously, and UNAIDS being created? And then third, some takeaways from the book. There's a lot more in the book, but we can't talk about everything, so we've picked those three things, but you're certainly welcome to ask us about pretty much anything else. We did our best, as you heard, to be as objective as we could. So what did GPA face? Now remember, I started in 1990. The program had started 4 years, or depending, 86, 87, earlier. But quickly, 7 quick things. The disease itself. Remember, there was a 10-year interval between infection and disease. So by the time GPA started, the disease had been widespread in communities around the world, particularly in sub-Saharan Africa. We had no idea how much it had spread, but it was a much wider problem. So GPA was playing catch-up from the beginning, and that got forgotten. Secondly, of course, the stigma, the discrimination, and the denial that at that time it was the topography of blame. This, of course, was due to the understanding how the disease, the groups that were affected, the modes of transmission. I don't need to go through all that here. The disfiguration, the Kaposi's, the wasting syndrome, and of course, this was a fatal disease. And so you had first a catch-up, and secondly, dealing with a fatal disease transmitted through mechanisms that were in themselves difficult for political leaders. Third was WHO's initial reluctance to respond. Now, I mentioned in some ways the response was feeble. And I did talk to Dr. Mahler about this. And he was frank, and he said that he hoped that this disease would be confined to the rich countries, that WHO would not have to get involved, because after all, WHO wasn't any good at dealing with, quote, social diseases. And I think Fakhri Assad, as I've already mentioned, why did this change in '86? One was that the work that Fakhri Assad had done as the director of communicable diseases. Secondly was the recruitment of Jonathan. And third was the very famous intervention in 1986 in the World Health Assembly by the minister from Uganda, who had the courage to stand up and say, we have AIDS, we need help. And that led, of course, to a number of other countries admitting that they had AIDS, and WHO could respond and help them deal with the early stages of the pandemic. The fourth challenge was, of course, later on, were the conflicting views on how to deal with AIDS. So there was a real serious difference of opinion on how to approach AIDS. There was what I would say the public health, medical, biomedical approach, there was the development vulnerability approach, and there was a human rights approach. And GPA tried its best to incorporate all these, but particularly after Jonathan resigned, it became more and more difficult to shake off the accusations that WHO was very much running a biomedical approach, medical model program. This was very hard for us to shake off, particularly as GPA was being attacked by a number of, particularly UNDP in this regard. Fifth, this then led to very serious competition among the UN agencies for resources. There was serious competition between WHO and UNDP, mostly because of the approaches, but this really frustrated the donor community. And as the pandemic worsened in the early 90s, and there were more and more cases coming, the donor community had really at one point said, we can't tolerate this competition anymore. If you can't solve it, we have to solve it. The sixth problem, frankly, sixth challenge was WHO itself. Let's face it, WHO's structure was not ideal for responding to a global health emergency like AIDS. And many donor nations, within 3 years of the start of GPA, when I took over, were already voicing serious concerns. And an external review was already underway in the fourth year of the program. The end of the third year, it was being discussed when I became director. Now, I will say that Houghton Mahler understood this. And when he set up GPA, he had the program reporting directly to the Director General, as had been the case with smallpox. And this gave it tremendous budgetary and institutional latitude. But when Hiroshi Nakajima succeeded Mahler, he insisted the program operate like all other WHO programs, which meant delegating much more authority to the regional offices and using the WHO country offices. I can tell you that we did all we could to assure donors that the program could operate as efficiently under such an arrangement. Gunilla Ehrenberg was going to come. She spent many months, she couldn't make it today, but she spent so much time helping to come up with a structure that would work, but we could not convince the donors, particularly in the Africa region, that we could operate efficiently. And then, of course, the last challenge that GPA faced, not the last, but the last I'll mention, were the performance of Nakajima himself. This, of course, the reason why Jonathan, and we studied this in great detail, the reason why Jonathan resigned was over differences with Dr. Nakajima over particularly human rights issues. Nakajima was very much focused on the biomedical vaccine aspects. John, at that time, had become very much focused on human rights. They also had cultural differences, personality differences, but as you will remember, in 1992, Dr. Nakajima got reelected under a very big cloud of suspected bribery and financial irregularities. And this also was very upsetting to the donor community. So as we got to the mid-90s, GPA was really faced with, and I'll talk about this in a minute, with desire to change the governance of AIDS in the UN system. But let's remember, please, and we go into this in depth in the book, all that GPA achieved. I'm just going to mention a few things here. It was really the first global response to the pandemic. It raised awareness to the pandemic very quickly and very effectively, and it spread. It formulated policy based on evidence. We were not hesitant. We had no inhibitions about the sensitivity of the topics we discussed. We developed a broad range of prevention strategies. We provided timely and comprehensive technical support to more than 120 countries. And I can tell you that is the thing we heard the most in our interviews, was the support that GPA had provided to countries. And one cannot overstate the praise that Daniel Tarantola was given from many people we interviewed for his leadership in this area. We established, for the first time in WHO, very strong partnerships with NGOs and persons living with AIDS. We learned very on in GPA, as had been learned in New York City and San Francisco in the 80s, that those countries that could have an effective response to the pandemic were countries that had strong community-based organizations and community responses to the pandemic. We had a comprehensive research agenda on vaccines, on drug development, on diagnostics, on epidemiological and social behavioral research, and we started dialoguing with pharma, and Josh Perians is here. Of course, this went on much more depth under UNAIDS, but it started under the period of GPA. So those are very significant developments and achievements of GPA that we develop in the book, and that people who work for the program, I don't think ever received the praise for what they achieved. Okay, so that's one aspect of what we cover in great depth in the book. Secondly was the transition from GPA to UNAIDS. So probably many of you don't know this, but the idea to close down GPA and establish UNAIDS in its place was seriously discussed for the first time at a secret donor meeting in London in March of 1993, which I did not know about. A final decision was made to close the program at ECOSOC in July of 1994, and we trace this history in the book. We're not going to go into depth here at all, but that's what happened. Now, what was the challenges that the world faced in light of this transition? So you're going to shut down the program at the end of 1995. You decide to do it in July of 94. It's just a global pandemic with millions of people infected, and it was at that time a fatal disease. So what were the challenges? Of course, for GPA staff, morale was terrible. There were great insecurities. We all knew that the program would close down on December 31st, 2005. But from my own experience and from talking to Steph Bertozzi, who took over the program, the work did not slow down. But many persons in GPA found positions elsewhere or in or outside WHO, but some did not. There was a messy lawsuit against WHO for a breach of contract, and I can say very honestly that neither GPA nor WHO handled this situation very well. Also, WHO was faced with another challenge, which was the mandate for UNAIDS created a lot of tensions among the co-sponsors. Most of them didn't want the co-sponsored program. It was endorsed by the World Health Assembly in May of 1994, and then GPA, and particularly myself, and Kathleen Crivero, we had to go to the governing bodies of the 5 other co-sponsors and get their agreement. And they didn't trust WHO. Most of them thought we were up to something fishy. And we were doing this for some reason because this was going to make the WHO more forceful or more powerful in the global AIDS response. It was quite the contrary. And there was also considerable tension between ECOSOC in New York and WHO as to who would have ultimate authority and control of UNAIDS. You need to remember that this was a time of UN reform following the end of the Cold War. And the UN in New York was seeking to demonstrate leadership in a number of areas. Particular Ambassador Richard Butler, it's a name you all know well from his work in other capacities with the UN. He was head of ECOSOC at the time. The challenge for countries was that all of a sudden, these 80 countries were, and I've already mentioned, this was the area that we heard GPA got the most praise for under Danielle's leadership, that UNAIDS was not going to have in its budget any support for countries. So the average country was getting, let's say, between $250,000 and $500,000 a year from a GPA. That just stopped. So as a result, up to 80 countries that had been receiving support suddenly weren't receiving it anymore from the UN system. We have no data on this, but you can imagine what the challenges this occurred for countries. One could even postulate that lives were lost as a result of this. And then the challenge for UNAIDS, well, UNAIDS needed to rapidly select a director, recruit staff, and set up a governing and operating structure. The selection of Peter Piot turned out to be a very highly politicized process, which we detail in the book. Finally, when Boudros Ghali made his decision on who it would be, because this was a decision by the Secretary General, Peter only had a year to establish the program in the face of tensions between the UN agencies, an expanding pandemic, and the plan to immediately shut down GPA. This was a real challenge for UNAIDS. And the behavior of the UN agencies were also a real challenge for UNAIDS. They had all made commitments. The leads of the directors and heads of each of the co-sponsors had met, and I was in the room with Boudros Ghali, and pledged their full support to the program. But at an operational level, as UNAIDS started to work, it found considerable opposition. First, among WHO, the regional directors were very upset about what had happened, and UNDP, for 2 years, refused to even shut down its own program. So UNAIDS had some real challenges getting off the grounds. And the third challenge that it faced was the donors. So the donors who had created UNAIDS and shut down GPA, they dramatically really wanted to shut down their multilateral funding for AIDS. And they did not hold the co-sponsors accountable for their commitments, and one could even postulate to some extent that one of the reasons they had shut down GPA was more to give more funding to their bilateral programs, which indeed was the case. And the actual budget for UNAIDS in the first 2 years was much less than what went to GPA. Now, let me say that UNAIDS eventually found its place in the global response. After the discovery of antiretrovirals, it helped to reduce the price of drugs. You just heard that in the last session. Advocating for access, it also took the lead in collection and provision of much-needed country, regional, and global data. It certainly worked a lot with NGOs in the human rights area, and this is very much described in Peter Piot's book, No Time to Lose. The creation of the Global Fund and PEPFAR, which we detail in the book, reshaped the role of UNAIDS because they had far more resources, but UNAIDS continues to play a major advocacy role and is responsible for monitoring the 90-99 targets for 2020. So that's a quick overview of the transition, what it was like for the countries, what it was like for WHO, and what it was like for UNAIDS. And we could talk more about how WHO responded to it, if you like, in the questions. So then lastly, Steve and I will talk about the takeaways. And we're just going to highlight a few. They're detailed in a very long last chapter where we try to say, well, what do we learn from what's happened? And these are obvious to you, I think. But first, mounting a global response to a pandemic, especially against a new and fatal disease, is a complex process. It takes an enormous amount of effort to develop strategies, recruit staff, raise resources, and maintain momentum. And this of course, is at a time when we couldn't use social media as you can today. Shutting down a program, no matter its perceived shortcomings, needs to be done with caution, great caution, and careful assessment. I think donor countries really should learn from this, not to be too impulsive when launching and supporting new programs, too impatient when demanding results, and resist shifting strategies for short-term gains. What is really ironic about all this, of course you didn't know at the time, is GPA was shut down 1 year before the discovery of HEART. And I cannot help but wonder what would have happened to GPA if HEART had been available 2 or 3 years later. A program that really dealt with treatment. Would GPA have been shut down and UNAIDS created? Who knows? I just put that out there. Second lesson is those responsible for financing and operating global programs need to be held accountable. Accountability is a big lesson in this story. The donor community and international organizations need to live up to their commitments, and there are many examples in the book where that didn't happen, the most obvious being the initial failure of the UN organizations to honor their commitment to UNAIDS, where this lack of accountability really wreaked havoc on lives and many of people around the world. The third lesson we felt was is confronting pandemics in general. It's really unlikely that for most pandemics we're going to have a magic bullet, and it's important to think about our approaches through a continuum, from prevention and control to therapy and care, remembering that prevention is usually a slow process, particularly difficult unless you have a highly effective vaccine, and when you have a disease like AIDS, and not just AIDS, but like AIDS, that evokes panic and discrimination. The types of battles, and they were pretty fierce, that took place in AIDS, that took place in the AIDS response between the public health model, medical model, development model, and human rights model were really unfortunate and should never be repeated. We need multiple strategies in confronting pandemics, and we need to be open to that. And then a fourth lesson we talk about is what did all this mean to the future of WHO? This has been discussed during the whole day today, Alona, but just to say a few things, there's no question that with the closure of GPA, WHO lost considerable prestige, although there were other reasons at the time why that was going on. And faced with its financial situation, operational shortcomings, and Michelle talked about this today, and crowded out by an ever-growing field of global health actors, really for 2 decades, WHO has struggled to find its place in the field of global health governance. It has scrambled to reform itself, and we document this in more efficient and is a focused organization, but really the changes have yet to materialize. It has excellent staff and programs, but it certainly doesn't have the prestige that it had when I joined it in 1978. When I saw what happened with the Ebola outbreak, Alona, my feeling was we shouldn't have been surprised. Now we have a new era in WHO. We heard about this all afternoon. Many groups have offered recommendations. We now have a new Director General. We have a draft 13th Global Program of Work. We heard today all the changes that are being promised. Of course, the question is, can they really be implemented? When you have the WRs that you have, when you have the silos that you have, is it really able to be changed the way the new Director General hopes to change it? And one can answer that in various ways, but that's, of course, a big part of the story. And then I think Steve will conclude with some other takeaways.
Yeah, I'll just sum up a couple that were interesting for me, both as a policy analyst and as a historian. Obviously, one of the most important ones, we try and track it in the book, is just the role of GPA and the issue of vulnerabilities, human rights, inequalities. The reality is that vulnerabilities matter. Of course, all of you know that, but really, it was until HIV and the work of Jonathan Mann and kind of pioneering this idea of health and human rights that there were other movements going on in Ottawa, the Syracuse, all that kind of stuff was going on. But the reality is that it really crystallized with GPA and pioneering this idea of health and human rights and making sure that that was taken seriously and integrated into some type of health planning. The other thing was that health systems matter, and I certainly, starting with Mann and some others and expanding on through, this idea that you could talk about individual vulnerabilities, but if there was not a supportive structure around people to address the needs or the lack of resources that they had to access care, you could have all the best laid plans, but the system, if it failed people, access was only a rhetorical device. It wasn't a real thing. The other thing was allies can be found in some really unique places. We talked yesterday about the role of religious communities in some surprising ways, and we've talked about civil society groups today. And with GPA and HIV, that was one of the first places where civil society groups, other than some of the large international groups, really came into the fore as being partners in the process. And I know UNAIDS very intentionally kind of incorporated the voices of people in the grassroots, but those NGOs on the ground became really, really important. Religious groups, Mike, one of the things he focused on in Brazil was the role the business community played in really coming to be partners in fighting HIV. And I think one of the things we're struggling with right now, we talked about this too, is progress is not always permanent. It's always a battle, and different administrations have different priorities and do things with budgets. The donors just decide we're going to go in a different direction, and that has huge implications for how we think and plan. And oftentimes people in organizations think this program will be here forever, and they find out that the rug gets pulled out from under them or the funding goes away, and now what do we do? One of the other issues is the science is complex. But donors sometimes aren't. So one of the challenges that happened, if you think about this, is the Cold War ended right at the start of this. So whereas before, donors would be funding part of your health program out of a geopolitical chess match. They didn't necessarily care what your health outcomes were, but they were wanting to make sure that Ghana was on your team and not somebody else's team. But as the Cold War ends, all of a sudden these donor nations start to care about how their donor dollars are used. And Mann is developing this health and human rights framework, which at that stage didn't have a lot of evidence for it. And certainly with Nakajima, who wasn't buying some of the things, having evidence in a complex set of questions and what are your outcome variables for a traditional public health doctor, that was hard to convince people. And donors are looking and saying, what are the outcomes that you're getting? How are these dollars being used on the empowerment of women when if you just hand out condoms, that is what I want to see. And so that can be a real challenge. So getting down to the science and doing the science in a way that gets evidence that donors actually understand and can use is very, very important. Scalability is really, really hard too. Sometimes we'd have programs that we'd studied that would work in a small isolated sense, but when you try and take it to a national context, there was regression to the mean or it didn't work. And sometimes entire strategies would be built on studies that worked in a small context, but when they got writ large, all of a sudden they didn't have the same desired results. The last one for me is that personalities matter. We can have the best laid plans, strategies, science, and systems, but it comes down to people running the show, and oftentimes people don't get along. Sometimes people are noble and selfless and humanitarian. Sometimes they're flawed and petty and dishonest and corrupt and territorial. And you have those people running those programs, and it doesn't matter how good the system is if the people aren't. And so some of the greatest tragedies that we try and track in this story are not just because donors or systems failed, which they did, but because people had petty differences or demands or cultural miscommunication, or they had personal animosities and they couldn't get over those things, or they couldn't work through those things. And those affected not just their programs, but the lives of millions of people. And I think, Richard Horton, in his review of our work, gave a nice quote that I'd end with, and that is that we have to pay attention to people and observe their imperfections and protect us all from ourselves. That part of this story is about people. And I think what we wanted to do was try and show that interplay, but also bring to the forefront the stories of folks like Yup Longa and Fakhri Assad and Jonathan Mann and so many others who their stories are sometimes forgotten, but they were the noble people often in this experiment of trying to address this pandemic that up until that time we hadn't had the opportunity to know how to face.
Well, thank you very much to both of you, and you can see the richness that is in that book, and we really hope that you'll take the time to read through it. Particularly, as I said earlier, you'll find part of your own story in it, and those that weren't born then when all this happened, you will get a fantastic history of global health and learn a lot of things that are actually also happening today, and to some extent repeat themselves. Before I open the floor for comments, stories, questions to the two of you, I do want to get back to this one point, because that's also what today was partly about, and that is really the politics of all this. And you alluded to it, Stephen, in terms of, this fell smack in the end of the Cold War. This fell smack a little bit later into the Iraq War. This was related to a direct Secretary General wanting to reestablish the authority of the United Nations. This meant a period of global health that was more or less defined by a hegemon, which was the United States and what it wanted. And then on top of it all, it did at one stage then have a new Director General who was also highly political, and who also took a number of decisions that partly helped create the Global Fund, but also setting different priorities and actually doing a lot in an area that we discussed this morning, like health security after SARS and the Framework Convention on Tobacco Control. So if you could say a little bit about those politics, because I personally think we tell a lot of stories of global health and in global health, but that political context is neglected. And you've highlighted some of it, but maybe there's some additional things you'd like to talk about that relate to this political context.
Maybe I'll start, and Steve, you certainly should supplement. I think first, let's remember that when AIDS started, there was a lot of fear. And we had no history of what to do. And so the donor community really turned to WHO. I think it's important to remember that the support that WHO received from 87, 88, 89 was remarkable. Up to 100, and that doesn't sound like a lot of money now, but up to $100 million a year, except for smallpox, which of course, I think the whole smallpox program was, what, $300-400 million, but the GPA was getting $100 million a year, which was a lot of money. And for a number of reasons, about the time I took over, things changed. And certainly there was more bilateral pressure in the donor countries. The NGO community, for example, in the United States, certainly was wondering why AID was giving all its money, or most of its money, to WHO, and why couldn't they have big bilateral programs? So there was this multilateral, bilateral politics around a new disease that occurred. That was one thing. Secondly, the second political dimension was a real concern about WHO being an operating agency. And this was particularly true in the African region. And when Dr. Nakajima came in, I've already alluded to this, and decided that it would run as a normal WHO program, quote, normal WHO program, not the way it had run under Mahler. This caused great concerns among the donors who had been reassured, that this wasn't going to happen when the program was set up. And I got caught in that, tried to make it work, but they didn't believe, particularly, and there were many stories in the book and elsewhere that we don't tell, particularly around the regional director and some of the problems that happened. And unfortunately, all the region suffered because the epidemic was worse in Africa and the response in Africa was the poorest. And that was the second political dimension. The third political dimension was the fact that, the one that you've already mentioned, that after the Cold War, there was clearly a 3 to 5 year window, and there were quite a few reports written, which we read, about UN reform. I mean, it's quite remarkable, led by the Swedes and the Norwegians, in particular the Canadians, who really felt that the UN in New York could be more than just a convening body, that it really could be a hope for the future at the end of the Cold War. And they were looking for opportunities to demonstrate that. And AIDS became that opportunity when the dissatisfaction with WHO occurred. Here was an opportunity for the UN to create really the first co-sponsored program under the umbrella of ECOSOC. That had never, ever happened before, no less in health, but in anything. And so this was definitely a move by the United Nations in New York to show, not necessarily to be anti-WHO so much, but to show what the UN could accomplish. It was quite striking to go back and read all that was happening during that period, and AIDS got sort of caught in that political dimension. I think that's what you're referring to, and it is true, and that's very much what happened. And the whole process of selecting Peter Piot as the first director of UNAIDS was an incredibly prolonged and complex process, riddled with politics, which we tried to tell in this story just so people realize just what you're saying, how political this had become around this time. So that's just amplifying a little bit of what you said. Steve, you want to add to that?
So I have a bunch. One of them, maybe that we touched on only, one of the reasons the Uganda statement stood out so much is because of the history or the residue of racism and colonialism. The reality was one of the reasons why African countries were not coming forward nearly so much about HIV in those period of times is because of particularly Western views of how, monkey sex or different types of behaviors that Africans have rather than the rest. And it was this whole idea that people, again, were blaming Africa for something. And so it was it was a stigma to be able to even come forward and say, this is something we need to deal with. And so there was a lot of resistance from African countries in fully coming forward with those things. And some of those things aren't just those countries not taking responsibility, but for Western nations, particularly not taking responsibility for the history that we have had in colonial, our colonial past. We've already touched on the Cold War. The other thing I will say with that, though, is certainly in the 1990s with UNAIDS, the funding drops off, but in part that's because several of those countries that we would have been giving to once upon a time now were not as important to us geopolitically, and therefore the United States can focus on 14 countries that it cares about rather than all of the countries. And that may sound cynical or crass, but the reality is all of a sudden some of those countries don't matter as much to us because we're no longer combating the spread of the Soviet Union. I studied domestic politics. The United States, particularly right-wing folks like Jesse Helms and stuff, did not want to fund the WHO and oftentimes cut the budget. So the fact that AIDS was a special program allowed the United States to pour a bunch of money into that one program rather than the WHO budget as a whole. But then that had strings attached to it too, in terms of promoting abstinence-only programs, and so the United States was really pushing it. And then when the GPA wouldn't necessarily go that way, the United States then starts to focus on bilateral things that it can promote, not just its own programs, but its own ideology that it wants to push in there. And so a lot of that was domestic politics in terms of what people are able to say or not able to say. And we touched on this morning, so I don't need to mention it, other than when HIV comes back to the forefront internationally is when we we recognize or create HIV as a security issue. And all of a sudden, when HIV is a security issue that donors then have to give a damn about, then all of a sudden we want to give a damn about it, because if it comes home to us indirectly, then we're willing to spend money on it. And so that is one of the strategic ways, and we try and track that in the book, about some of the ways that we used security to get HIV back on the global agenda.
Remember that PEPFAR gets announced by President Bush in the same State of the Union address as the bombing of Iraq.
So, over to you. Comments, questions? Yes, please.
Hello, my name is Matt, and I'm curious, you talked about holding donors responsible. It seems to be currently an issue as well, and I was curious if you had any success within that.
Well, I think what was clear once spending a lot of time talking about the formation of UNAIDS, the donor community made a lot of promises about shutting down GPA, shifting quite a bit of the money to UNAIDS, and also the donor community had promised to work with each of the UN agencies who were the co-sponsors to put in their own money from their own budgets, which hadn't really been the case. When UNAIDS was actually formed, that didn't happen. There was a body formed. You can read about the name and all that, but there was a governing board formed with the donors. But if you read in our book, or if you read Peter Piot's book, we describe in here some really tense moments where Peter says, I can't run this program, you're killing us. You're cutting the budget that you gave to GPA in half. And so it was two things I want to be clear about. It was giving less money multilaterally, but it was also, well, three things: giving more money bilaterally, and then thirdly, not putting pressure on the individual co-sponsors to really be active in UNAIDS. That was the deal. The deal was that each one of the co-sponsors would put in their own budgets. UNDP continued to run their own program for 2 years. WHO, frankly, the regional directors were so upset with Dr. Nakajima, we have quotes and good evidence that a few of them hoped that the UNAIDS was going to fail. So it's a complex story and a difficult time, but please remember this is a global pandemic of a fatal disease, millions of people getting infected at a time when people are withdrawing. It was tragic in many ways. That this development occurred. It was almost like the pandemic wasn't occurring. It's the only way I can say it to you. When you look back, as we've looked back almost 25 years on what happened, it was clear. But I don't want to say the donors are the only ones that weren't responsible. The UN agencies were not responsible, okay? And it was the countries that suffered.
I think we'd say, though, the difference is the donors can pressure the agencies to act. But we all know the truth of the matter is that if the United States wants to take its ball and go home, it's only social pressure that's going to make, there isn't a leverage point to say, you need to do that. We've learned. They can back out. And so we don't have any success in making countries do what we want them to do. Other countries can try and work to do that. But the reality is that's one where it's just moral suasion and shame.
But then, tell a bit of the story, which again, of course, is a political one. How come they then reorientate and create the Global Fund?
Well, for me, the turning point was treatment. I think the donor community, I think that, of course, Michelle CDB left, but the fact that you had treatment that was life-saving, the dramatic impact it had, but you couldn't get access to it. So it was too expensive. And so what happened in the Durban conference in South Africa, the taking to the streets, the embarrassment, of, rightfully so, of pharma for not dropping the price earlier. We describe in the book some efforts in 1992 by GPA, which we couldn't talk much about then, to actually get pharma ready, because they knew these drugs were coming, to drop the price. And they refused. I actually spent hours discussing with pharma. They wouldn't drop the price. And we had a debate about whether we should still go ahead and make the drugs available. But there was, I think treatment was the turning point, Alona. And the fact that finally there was a way to really make a difference in the pandemic. And when the price came down, it seemed to me that there was a great opportunity to save millions of people by getting the drugs out. And that was the turning point. In my mind, more than anything else, we medicalized, after fighting so hard to have a broad multidisciplinary approach to AIDS, very much we medicalized the response for good reasons, because we could make a really big difference.
But I would also say there's political stuff involved. So one of them is Al Gore wanted to be president. So there's some domestic pressure for Al Gore to have kind of a global statesman position. And so he has this issue that he owns. And Kofi Annan obviously has some UN institutional incentive that he also wanted to back those things. And at the exact same time, conservative evangelicals in the United States at that stage politically got mobilized to care about innocent orphans in Africa dying of AIDS. And so the mobilization of organizations like World Vision, Samaritan's Purse, back when Franklin Graham had different, more equitable political positions. They got folks like Jesse Helms all of a sudden to care, because those were innocent people that we could fund through. And you know, Bono comes in at that stage too as a way of, and that was when there was this shared vision among conservative Republican Christians to say, and so if you can remember, the Bush administration had this compassionate conservatism. I don't think compassionate conservatism can function in the United States anymore. You'd be a liberal. But at that stage, people mobilized conservative Christians. And I think those three things together, I mean, Holbrook obviously plays an important role in figuring out that this is a problem that needs to be acted on. So
that's the political dimension. Yeah. So.
Yes, please go ahead. Okay, first Daniel and then here. Yeah.
Hi, Mike. Daniel Loba. It's been like a puzzle for me putting together this history, and I've learned a lot from the people in the room when I talked to Daniel, when I talked to others. I was very junior, so my role was just looking at the results of the program. I was quite junior in the program, 93, 94, 95. I've then looked at the results of the Global Fund, so I've done that work a little bit afterwards. And the first point maybe you can comment is the thing that really struck me, you mentioned it, but this was WHO treating a health issue as a social response. So you come into this program and you know, there were people working on behavior, there were people working on human rights, and they were putting this into a public health model. And it's one of the few times actually WHO has done that incredibly successfully. And then the second one was WHO implemented, you know, all the way down with no levels, you know, from global country, you'll be in communities, you'll be funding TASA, you'll be supporting in Thailand the response among NGOs. And those two components were really quite, you know, distinctive for me, and I'd like to hear your views on that. And then secondly, I mean, I was looking at the results, and the results were really quite spectacular when you did those two things. You know, 94, 95, I've never seen when those were done, and they were delegated to the country, to the communities, infection rates tumbling. You know, in Thailand, when we looked at the data, 10%, 5%, 4%. Uganda, the gay community in the States, among drug users, among the groups you would not normally see. You just take one country, the Thailand response, you know, 10 million lives saved, equivalent to the Global Fund lives saved, 100 million per year compared to 10 billion. So the results were quite spectacular, clearly with gaps. I remember at the end quite a memorable meeting where we presented those results in December 2015. Quite a small meeting in Uganda, who turns up? You have Nakajima, you have the head of the WHO program, you have Peter Pia, you have Museveni, all on a table trying to show these results, differently. You can't have a direct response with WHO. It's a multi-sectoral problem. It will take 15 years to show any results in Africa. It took us a while to get those results out. I mean, we published them finally in Science in 2004. And it took quite a while to show those results of that direct program. And then the third point, when you look forward for me, would be those are probably the components that are still missing from the HIV response. When you look at the infection levels and their strengths and weaknesses, the treatment response has got successes. There's some things that have been added. But a public health response focused on a Ministry of Health that could treat a health problem as a social issue and could implement without all these levels, without coordination among donors and then a plan you have with ministers of health and then a separate forum that does civil society. So I was wondering maybe if you could just comment on those. Did it show something in WHO we can learn from? Just the results of the program, how does it compare? And then thirdly, are we missing something of that in the response today?
Well, I think if you have a chance, you will see we did our darndest in the book to document what you said happened, to show what happened, to show with graphs and figures on specific country examples on what GPA achieved. I personally read through the Uganda file. It was huge in the basement of the M building, or the Thailand file. I mean, I didn't read every word, but I went through it. I mean, it was remarkable what GPA did. We also, at the time, tried very hard to have a multidisciplinary or a multi-strategic approach. I can tell you 5 times at least I asked Elizabeth Reed at UNDP, okay, you feel we're not doing more in vulnerability, in development. Here, tell us what you want to do. We'll do it together. That wasn't the interest. The interest was getting money for UNDP to do it. So I think we were faced with a period of time where, although we were trying, certainly when I say we, going back to Jonathan, to do just what you said. And I think a lot was accomplished. That is why I really wanted to write this book, because that story had never been told. Well, it had been told, but not thoroughly, and we really tried to tell it. Unfortunately, Jonathan died and never really put the whole thing together. He wrote some papers, but there was AIDS in the World, the book that he and Danielle and others wrote, but there was never really the story of what had happened in detail. And so that's what we tried to do. Now, could WHO do this today? I'm not sure I'm the best person to answer that, Ilona, but I would say the response today is different because you have treatment. And from the different committees I sit on in various forums, the big issue with the response today is the lack of a serious attention to prevention. That is really, as I understand, I sit on PEPFAR committees or Global Fund or whatever, or different groups, and you hear what the complaints are, and that's because the main focus is to get drugs out for treatment, because we know, and Josh, you can verify this, but people that are fully treated won't transmit. If you have people with no virus, they won't transmit. So there's now a big emphasis on treatment. PEPFAR is, no matter what you hear, is a treatment program. They make lip service to other things, and they do have the DREAMS project in some African countries, but it really is on vulnerability of women. But the real threat now, as I understand it, is particularly in the southern African countries with a great increase in youth, that there are rates now of 15, 20, 25, 35% prevalence coming again, particularly in young women in southern African countries, because there isn't enough attention being dedicated to prevention. Could WHO take that responsibility? Someone in the room would have to tell me. I have doubts that they could. As I mentioned in my opening, Houghton Mahler was even afraid of WHO taking on this problem, and the only way he would take it on is having it report to him. There was a fellow named Joe Cohn, some of you may remember, who was his special advisor. I'm sure Ilona remembers him. He was a character, but he was shrewd. And he really insisted the program report to him and Mahler, that was the only way you were going to get WHO to respond in this comprehensive way. And that was lost when Mahler left. Steve, you're maybe more objective on this.
No, I mean, so that's one of the things, obviously. I mean, the fact that Mahler had it operate outside of the traditional WHO structure allowed the program to have the flexibility to do some of that multi-sectoral response that it might not otherwise have had. And I think the best that Mike could have, he tried to maintain those types of things, but the reality is bringing it back within that structure, brought it back within the structural limits that WHO has. I think the other thing that I should point out that you mentioned, I mean, there's two things there. One is some of the countries you pointed out where the greatest successes were seen were ones that had political leadership early on who recognized this is a problem, and from the very top, we're gonna take action on it. So Uganda, Thailand, Brazil were ones where they said, we're going to take this seriously and we're going to do something about that, right? The 100% condom thing in Thailand, and of course Uganda with Museveni. Other countries were coming along, but right in that is they'd started the review process in 1989, or that was when it got called for. So the external review process has already started around the time when Mike comes on board and Mann leaves. And by 1991 or 1992, I interviewed Jill Walt, and she said, basically, we knew that where the program was going. So results in 95 that show efficacy are wonderful, but the decision was made 3 years earlier. And so there wasn't any stopping that train at that stage. And so that's one of the challenges with science, is it doesn't give us 2-year increment, outcomes that we can action upon.
Well, there's actually a parallel, if I can add that, and that is the health promotion program. Because also Mahler and Cohen felt a need that WHO needed to handle the social aspects of health much more than they did. And they decided that this could be, a program for health promotion. They actually were, so fearful to put that in headquarters because of the lack of context that would support it, that they actually put it in the regional office of the WHO and asked a young come-up, which was me at the time, to run it. It also reported directly to Mahler and Cohen. And even bypassing the regional director, he got the okay of the regional director. I was the only person in the regional office of WHO that could call Mahler directly next to the regional director. So that was quite a balancing act.
Yeah, you would admit that caused tensions for destruction.
But the point I wanted to make is that they try to find these kind of things to get the social on the agenda. The minute Nakajima came into office, he closed down this program in the regional office. He put it in some headquarter structure, and from then on it went downhill. So you can actually see the parallel quite clearly, even though, the health promotion program never had the size or anything of the HIV/AIDS effort. So there was a consciousness with Mahler and Cohen, we've got to do something else. There was, of course, a close friendship between Mahler and even Illich, who kept telling him, you're not doing the right things, half done. Medicine is not going to resolve all this. And so, they did these things, but in the end, it wasn't crowned with success. But you were going to say something.
Thank you, Ilona. And thank you for the panel, for the very important presentation. I'm Francisco Songane. I wore many hats. I was Minister of Health in Mozambique for 5 years. I worked for WHO as the founding director for the Partnership for Maternal and Child Health. I worked through the Global Forum, and then I ended up with the UNICEF in Angola. So the issues I would like to raise to contribute to this presentation, which is, I think is magnificent. I think that we could label it as an honor to the very important and teaching movement, the grassroots movements for HIV/AIDS. I think is a main professor for many public health students. I think the success we're having today is in regarding the action took by that movement. I hope that in the book is properly captured. Michael, you alluded to the Durban conference. I think that was a historic moment. You should have been there to really feel that change. No, I'm just in general, to really feel the wave from the conference center up to the place where the reception was held. It was a sea of people, of activists. You felt impelled, moved. You had no way to escape. After that conference, I think the whole thing changed. The political leaders became fearful. Because one issue we had in Africa was full denial. It was a major problem. You could not talk about it. It was a sort of criminalizing the people who were affected. It's bad behavior because you are like this, you are getting HIV/AIDS. Will never touch me. I think we're repeating the example of Yoweri Museveni. I will repeat again. He is the leader who stood up in terms of the fight against HIV and AIDS, and he contributed significantly to change the whole thing. The other thing I think it should be really emphasized, Peter Piot, he was the political leader who took this and moved as a politician. He did not move this as a medical doctor. He took the political stand, he elevated HIV/AIDS through the political battles, through the political corridors. And he combined it very well, his action, it's a pity Michel Sibide has left, with a good communication. You would read communications coming out of UNAIDS, you'll get the picture clear on your face about your region, about your country in a simple, direct manner. The lead epidemiologist then was Bernard Shatlander, who was, is that? He played a lead role in really breaking down this complex information in a way you'll see the picture of Southern Africa there as a very important area, has the epicenter of the epidemic. You could see it clearly. You didn't need to go to a public health school to understand that. And apart from becoming or being labeled as a security problem, it was clear to everyone in Southern Africa that it was a major economic problem. It was affecting young people, the workers in the industry, in every kind of activities, including the businesses of the big powers from the West. They had many businesses there. They were getting affected. So it was a combination of security and economic threat that led the donor countries to change their mind. They said, let us fix it because it is affecting us in a due direction. Another thing I would suggest, I don't know whether it is there, I didn't read the book. It will be important to highlight the important role which was played by the MSF in leading the work of analyzing and discussing the modalities of treatment and demonstrating in their analysis that it's possible to treat using cheaper drugs and resort to the contribution from CIPLA. I think that was a turning point. In a way, to the shame of the institutions which should have done that, was MSF doing that and produced that document which demonstrated and proved that, hey, this can be done safely, effectively, without a problem. And from that publication from MSF, all the countries said, we cannot do it, let us do it together. I think that's extremely important as a contribution. But I come back again to end where I started. The grassroots movements, I think, was a major teaching opportunity for
Right,
HIV.
but just very briefly, we do cover the importance of Durban, that conference. I can tell you, one of the last things as director we were able to do was to get the International AIDS Conference to be held in Durban, because it had never been held in a low-income or middle-income country. All the conferences had been held in the developed world. I was always sorry we couldn't get that done earlier, but that was a critical decision, and it very fortuitously, it nicely coalesced with the idea of the drugs being available at that, and the possibility to bring the price down. So as I mentioned, that was a really critical turning point. We also describe in the book that Peter really makes a decision that Jonathan made, which was the biggest impact he could have, Jonathan Mann, was on advocacy and on really being the world spokesperson. And in this case, for Peter, it was very much bringing down the price of drugs and making them widely available. We don't go into the MSF work with Doris Schapper here. I'm sorry about that, but Doris is a major, I don't know if she still is, but very much involved in MSF. But certainly, a lot of that is in Peter's book. We don't go into great depth onto all the work that UNAIDS did. That would have been somewhat duplicative. What we try to show is the course between GPA to UNAIDS and then PEPFAR and the Global Fund to where we are today. So we don't go into great depth on all the advances in treatment.
Thank you. So already it's 2 books you have to read. Okay. Well, now we have a lot of... Let's start here, please. And please, if we can be shorter, you can all speak. Otherwise, I have to close.
Okay, thank you. Thank you very much, Mike and Stephen. And I'm afraid I haven't read the book yet, but I'm very excited to do so.
Could you introduce yourself?
Yes, my name is Susan Timberlake, and I served with Mike in the Global Program on AIDS, and then for many, many years until 2014 in UNAIDS. So I was there for the transition. And what I wanted to bring up was the point you made, or you both have made, about bringing together health, human rights, and development. And I fear that in the co-sponsored program, when we started UNAIDS, the idea was that UNAIDS would be one idea, there were many, would be that UNAIDS would be the secretariat and that the co-sponsors would deeply embed and mainstream HIV throughout their work. When the money started pouring in, what happened was that everybody went for that money and created very big HIV departments, which have accomplished a great deal, but that mainstreaming never really happened, in my view, throughout the agencies. So health has suffered, in that sense, from having that more holistic approach. Human rights a huge amount has been accomplished in human rights terms, mostly by the people most affected. The man mentioned the grassroots movements. But human rights has always, been heavily avoided by governments and even by the agencies because it speaks of obligations that governments want to avoid. And secondly, human rights, there's been no serious money put into it. Now, the Global Fund right now is trying very hard to put a lot of money, well, not a lot, a tiny bit, but more than it has ever been put into programs to reduce human rights-related barriers. All of this is to say that what I'm very afraid of, and I'd love your views, is that the gains we've made by bringing human rights into health, I fear could be lost because now, with the money reducing in HIV and the money desperately needed for treatment and not enough there for treatment, that's where the money's going. And it's not going to support the community systems or the health systems or the human rights programs that needs to be supported. So I feel like what we're going to end up with, and this is my last point, we're going to end up with another, if we ever get to the so-called end of AIDS, it's being defined as no longer a public health threat. What that means, I think, is that it's going to be a disease of poverty, and it will remain in the poorest and the most marginalized, and the world would get on and forget huge lessons learned.
Thank you. Over there, please. Somebody had raised their hand here? No? No? Yeah.
1, 2, 3.
Yeah. Yeah, oh, it was you. Okay, you first. That's right. No, not you. No, I'm sorry. No, the lady behind there. That's the lady I was looking for. I knew there was somebody here. Sorry about that, but she was first.
Thank you. My name is Anne, and I'm with the Swiss mission to the UN. My question is, looking at right now the efforts at WHO to reform itself and the role it wants to play in terms of operations and especially what was discussed this morning in terms of emergencies. What I hear two messages. One is that GPA achieved great successes and so that WHO can achieve a lot with its operation. And at the same time, I feel that I hear sort of a pessimistic, fatalistic message that WHO can never meet the expectations that it's raising. So I was wondering what really are your lessons learned in terms of the of WHO being operational. Thank you, and its role.
The gentleman with the here, and then you can pass it on. Yeah, you'll get it.
Thank you. My name is Chema Calleja. I used to work in GPA in Africa in the times of 80s and 90s. So I have been reading the book in the last couple of days very quickly, and I find very useful and very interesting. So thank you for writing the book about GPA. So I just want to ask some questions about the future, not the histories of the past. So you have mentioned 3 challenges, or 7 challenges. Your 2 of them, one of them was the structure of WHO with the regional offices and the different kingdoms and different entities. Also, you mentioned that the other issue, a big challenge, is that, what was the other one? The number 3. The biomedical aspects in which Nakajima was emphasizing now at that time, and I think also taking the point you have mentioned now that with the biomedical approach now overtaking the prevention programs, bilateral and multilateral, we are perceiving that we are in the same direction that we have in GPS. So my question is, based on your challenges and the shortcomings of the programs, bilateral and multilateral, what should be your advice or your point of view now for the future to really to end AIDS in 2030? How is the goal? Thank you.
Thank you. Pass it on, yes.
Yeah, a brief addendum. The own donors, own contributors, exactly in the UN system, as I hear you, it's true, because since then, other international organizations, they adopt their own program on AIDS, adopted by General Assembly, which is the case, for example, Postal Union, their own department on AIDS, adopted by all state members, ILO, International Labour Organizations, IFRC, at least 3 international organizations nowadays. Thanks.
Thank you. All right. Never mind.
Okay, let me just very briefly. Mainstreaming was what I was referring to before. The donors never, although they talked a lot about it when UNAIDS was formed, they never put pressure on the agencies to do the mainstreaming. As you say, everybody ran for the money instead of the mainstreaming, and that was what had been promised. So you're absolutely right, that did not happen. On human rights, I would say to you that when I have talked to people today, the biggest deficiency in the response, the fear is that we've lost that community response. That what we had, we're losing, and that we don't have near the amount of resources. PEPFAR talks about it, but the amount of resources really going into the community response is not nearly enough. And I think you're very perceptive, and you're completely correct in that assumption. And I think we never really, I think, figured out. I remember you telling me this, how to really bring human rights into the community response in a way that governments would find acceptable. This was a challenge. I know you worked many years for that to happen. And I think it's a combination of never really instilling it enough and then not having now enough community support. So I agree that that is under threat in terms of our response, particularly with the emphasis on drugs. I think in terms of WHO, please remember when GPA did what it did, it had close to 400 to 500 people, half in Geneva, half in the field, working on one disease, reporting to the Director General with a very substantial special program budget, up to $100 million a year. I don't think that we're going to see that again in WHO. So yes, could WHO reasonably implement under that situation? The answer would seem to be yes, from GPA's experience, but I'm not sure that has much to do with whether the reforms that WHO now needs to operate as an efficient agency are the same. It's fine to write, I mean, I listened very carefully to Michelle today. The 13th General Program of Work is a beautifully written document. It says all the right things, but to turn around an organization that has had the kind of problems that WHO has had is not going to be easy. I think we need to do everything we can to support the Director General, but it's going to take patience and time, and I'm not sure how long the world will wait. I mean, I've already seen that with the emergency response today, Ilona, how there's already some impatience regarding the actions that WHO is trying to take in that. So I would personally hold WHO to the fire to really be sure not what they say is one thing, but do they really substantially make the changes to accomplish what's in the 13th General Program of Work? That's going to be critical. I don't think GPA can help in that way because the enormous amount of support it had and the place where it stood in the organization. Ending AIDS. So I have been in numerous meetings on the end of AIDS. There's even an end of AIDS coalition that Kenneth Cole, the fashion designer, is trying to start a campaign about. And I think there's a lot of, recently UNAIDS had a meeting about how do you define the end of AIDS. I don't even think that's been decided yet, what will constitute the end of AIDS. Certainly if there was an end of AIDS, then the donor community could start to not feel they had to give the kind of resources that they're giving. So there is a political desire, Ilona, I think, to define the end of AIDS. There will never be an end to AIDS just with treatment. I think there's hope for a vaccine. I think a cure is less likely. But we still need to take our preventive messages and community responses seriously if we're going to end AIDS. And someone has to define, some group is going to have to define what we clearly mean by the end of AIDS before we can talk about it in a serious way. There are efforts underway to do that, particularly being led by UNAIDS that I'm aware of.
I don't have a lot to add to that other than, yeah, and the other thing is WHO operational, but people being unsatisfied, I think you should just get used to that. Because even if no matter what, even if they're successful, there's going to be somebody who's impatient and upset about it. So that'll be, I think one of the things that Jonathan Mann really tried to do was build the human rights perspective into the culture at WHO. And Daniel can talk about this more than I can, but increasingly there's good evidence to show that it has an effect. I do think there is a branding problem. People don't like rights, and I think there's folks in the health and human rights community who have started to try and articulate what a health and human rights perspective is, and it involves certain series of things that include access and some other stuff, and there are ways of maybe avoiding the terminology, but making sure that each of those things is part of the programs and interventions that take place, and that's a way of, but even then, ensuring access becomes something that some nations are really opposed to. In the United States, we've really struggled with the extent to which we feel obligated to do some of those things. But I think the idea that the WHO or whomever health providers have to have is choosing to make that one of the criteria by which you plan, implement, and evaluate programs, and there's no other way around doing that. That's going to have to be an institutional choice. And I think we have examples in the book of where, like, the WHO decided if a country has travel restrictions on HIV, that WHO is not going to have any conferences there. I mean, there's things that we can do that kind of try and drive those points home.
Okay. Dario, can you tell the I want to say again to all the GPA people that came, I hope we did well with all that you tried to do and accomplished. I hope you have a chance to read some of the book at least. It is available as an electronic copy if you prefer that. But really, I felt that story just had to be told. I'm sorry it took so long to tell it and get it out, but I hope you feel we did it justice. And it'll be something you will remember and be proud of, even there might be parts that are a little painful to read. I hope you'll be proud of all that you did. Dario, can you tell them where we're going to have a little, for people that want to stay a little longer, where the reception is?
Yes. Yeah, there are actually two receptions now, because there's one downstairs, which is for the day, and then the other one is at the restaurant Maison de la Paix, which is at the 6th petal. So you have to get out here from the 2nd petal and then walk towards the UN, basically. And yeah, you just follow the petals, basically.
What,
and the
number
6th.
6?
Yes.
At the roof.
Yes.
Thank you.
Okay, so I'd like to thank all of you. I don't have a microphone anymore.
Yes, we've done.
Okay. I'd like to thank all of you. I do want to make one or two short comments. One is that one of the reasons the WHO emergency program was constructed like it was is actually related to this history. And you will remember, Mike, I interviewed you on behalf of the independent panel. And because of the conflict that was there between the Director General and the head of the program, we suggested that an independent oversight committee be created for the special program for emergencies, so that if need be, there is a broker between the DG and the emergency director, because we could well envisage that there are situations where there might be such conflicts. So I think that was maybe one part of the history that people might not be so aware of, that actually this was looked at very carefully before creating the emergency program, and also that operational role actually goes back to this history. So that's maybe something else as you continue that you might want to look at. The other learning, I think, has been that since the Global Fund, we have had no other such fund, despite people calling for it a lot. So I don't know if that's learning on behalf of member states. And the third thing I want to say is that there is an extraordinary effort right now at WHO. And whereas I can think, particularly maybe some of us who've been around longer and have seen a whole number of such efforts to reform the organization, still I think as long as we can still contribute, we should try and do our best to help with that change. It's enormous. I'm presently seeing it both from the inside and from the outside. The effort is extraordinary. It's incredibly difficult to turn around a tanker like that. And I just really, really hope that the member states will give Dr. Tedros and his team the time and the space to actually do that, because that's not something you can do in 2 years. You definitely can't. You really also have to change the whole culture of the organization, and a whole number of you have referred to that. So I think there's a lot of learning in here, aside from reading one's own history, also with the last chapter. And yes, it is present. Even decisions that are taken on global health governance today are influenced by this story. It might not always be that visible, but it is there. Thank you very much. First go to the one reception and then to the other, I guess. Yeah, okay.